Good morning. Can you hear you right
Good
and clear?
morning.
Can you hear us?
Okay.
Right, I'm Dr. Dewadi. I'm one of the
Yes, we can
interventionists from
clearly
Manchester.
hear you.
I'll get my other chairs to introduce themselves.
Yeah, I'm Dr. Kumar, co-chair. I'm Dr. Mukesh Sharma.
Right.
Would you please introduce your team at Asan?
All right. First of all, I'd like to thank you inviting us for the NIC 2016 a fantastic meeting in India. And so we are very happy and honored to participate this live demonstration course. Okay, actually, so we have teams, Dr. Bach, Dr. Bach, and Pyong Lee, and Cheryl Lee, and many staffs actually work in the Saturday afternoon, really. So we actually prepared the 2 cases of main disease intervention. So if you don't mind, we'll start at the first cases, right?
Okay,
So
yes.
Dr. Bach will present the first cases, and
Yes.
then we want to show some real coronary angiogram too, right?
Yes, this patient is a female patient, 73 years old female, and admission with after chest pain. And this patient has a particular past PCI history. 2 years ago, this patient has LAD ostial lesion, so underwent stent crossover from the LAD ostium to the distal left main. 1 year later, and they experienced ISR, the LAD ostium, so received the drug-eluting balloon for that lesion. And 6 months later, this patient has also recurrent ISR, the LAD ostium lesion, so repeat the balloon angioplasty. And this time, we have another subosteal stenotic region, and the risk factor is hyperlipidemia, no diabetic, no hypertension. The ejection fraction was normal.
Okay, so as you heard, actually, would you show the angiogram? Okay, that's good. So this is the angiograms just showed, minimal intima hyperplasia was stented segment from the LAD to left main as may intermediate stenosis, and critical narrowings of a circumflex ostial part, very discrete. However, this is clear, the significant stenosis. Would you show another view?
Yes, spider.
Okay, there on. All right, this is spider view. It's clear. Some Hedges and very tight stenosis and circumflex ostial part, and some intermediate stenosis and LAD stented segment. And so we're gonna treat, restenosis or circumflex ostium, non-stented segment, and we have to consider again about the main stented segment from LAD to the main.
Yes.
This is, the stent crossover, the circumflex ostium. So, okay, any
just
discussion
wondering,
point, any
having
suggestion for the?
Having any stent with stenosis already, plus the fact this is a distal bifurcation left main disease, has there been any thought about surgery? Has there been this MDT discussion with the surgeons? Have you discussed with the surgeons possibility of a bypass operation?
Actually, the case is, yeah. All right, so we clearly consider the possibility of bypass surgeries. However, a circumflex ostial part restenosis would be the first time. And this is very angiographically discrete lesion. And the intervention is side, as I can do the intervention, repeat intervention for circumflex ostial part. It's very clear, so the other major vessel, So LAD is, hemodynamically, it's good. It's not a, functionally significant stenosis. Maybe mainly related with, circumflex ostial disease. And so still, I believe, PCI would be, another option for particularly this patient. So Okay, it's good. Reasonable, options, surgery, okay, at any time so for the main disease, surgery is good. Any other suggestion for that? Another view, please.
Would your strategy be the same had the patient been diabetic?
Oh,
Did you hear us?
No diabetes.
no diabetes.
But had he been diabetic, would the strategy, I mean, what is your strategy overall? I mean, PCI, yes, but what is your plan?
For the main disease?
Yes.
All right. You may know that last 2 years, lots of changes in terms of ESC guideline and even in the HHS guideline for the main disease. Personally, I believe still I don't believe too much about the morphologic stratification, just like syntax score itself. However, if you look at the guideline concern, low and intermediate docile, any main disease is still good candidate for angioplasty. The meaning is for the main disease, whole populations, at least more than two-thirds, exactly say is more than 67%, almost 70% of cases would be good, for the intervention. So as a personally, I believe you showed the previous one.
Yes.
So I believe this kind of simple, not simple. So this is regional cases. However, morphologically quite simple, and the other vessels is good. Still, I believe it is a good candidate for PCI. That is my.
So that's good. So what is your strategy? How do you plan to do this case now?
Right. So actually, we are gonna do IBS evaluation in both branches. However, before that, according to based on the angiographic findings, it's mainly ostial circumflex disease, and so we have some options. Balloon angioplasty and just drug-eluting balloon for the discrete narrowing of circumflex ostium, and another stent for the circumflex ostium. Whatever you choose, the tap technique or Kulo technique, I think it doesn't mean anything, right? So just we can do another stent for the circumflex ostium, and then for the LAD side, the stented cement, we're gonna see that what's happened, by IBS evaluation, and maybe related with some underexpansion or intima hyperplasia. Depending on that, we're gonna do the more stent dilation if the lesion related with the underexpansion, etc. However, if there are enough stent expansion and intima hyperplasias, we want to do simple plain balloon angioplasty first, and or sometimes we practically prefer cutting balloon for the stented segment, and then from the beginning we discussed about that. It's just the circumflex ostial part. We're going to choose another stent. And then LAD side, we're going to do the, depending on the morphology by IBS and cutting balloon and drug-eluting balloon for a stented segment and new stent. In terms of a technical concern, I prefer, particular for these cases, as a tap technique, so minimal, a proximal stent protrudings in the main branches side. It is more, easier to do some procedures, even in the, complex main disease. So that is our plan.
Have you thought about using?
Any other suggestion for that?
Have you thought about using a dedicated stent, in particular in this case, maybe a Triton?
I'm sorry.
Have you thought about using dedicated stents, in particular in this
actually-
case, using Triton stent, because it's almost like having less metal in the left main?
Right. You mean,
Triton
to
stent.
be honest, I don't have any experience about the dedicated stent. Triton stents, you suggest the main branches, circumflex stent for? What's your
You put the
suggestion?
Triton in the circumflex, so that
Is it the
gives you-
LED?
yeah, and then that gives you opening to the LAD, and then it becomes almost like a culotte, but without having to put more metal in the left main.
See. All right. I think that is another option. However, frankly, I have no experience about that. And so up to this point, we have some very interesting data. Many kind of two-stand technique, you know that, currently, we use mini crushes, cooler technique, the T-stand tap, any two-stand technique. So we can make a good clinical outcome using the IBS, guided optimization concern. And so whatever you choose the two-stand technique, even I have no idea, dedicate two-stand. Is it two-stand? After the two-stand, how big stand area is most important key, predictors for the good clinical outcomes. And so whatever you choose the two-stand, cross-sectional area is very enough to, 5, 6, 7, 8. In the later, we're going to discuss a little more. For the circumflex ostial part, 5 millimeter square, and LAD proximal 6, polygonal confluent, 7 millimeter squares, and then main distal 8 millimeter square. So we have some, 5, 6, 7, 8 rule for the drilled stand for the good clinical outcome for the two-stand technique for the any, the main disease, right? Okay, so we're gonna just, there are some difficulties. Would you show us the previous one? Wiring is quite easy to the LED, previous one? Some difficulties, right, that one. Some difficulties across the central with wires. And so actually we choose the choice PT wires. That is, hydro coating. Hydrophilic coating wires. I prefer, in some cases, through the stand strut. I believe it really is more easier too, So we pass the choice PT wire, and then we have dilated 1.25 millimeter balloon for, expanded space, stand strut space here. And then, okay, we are doing the IBS examination for the LED first, and so we have a more, detailed morphologic insight from the IBS examination, right? So we just flushing again is to, okay. So, Pyong Lee, would you read the IBS finding?
You can see the distal part of the previous stent, and there are lots of instant restenotic plaques. You can see that in the 9 and 12 o'clock. And this is the mid portion, I think, at the LAD. The stent diameter is about 2.8.
Here. I have it, focal.
There are some plaque in the
Intima
portion here.
hyperplasia,
Yes, right? Wow.
Mainly. All right. Stent diameter is almost 3.5, or the meaning is stent expansion is quite good, right?
Right.
Is that already there? And mainly intima hyperplasia is the cause of this ISR. Proximal part, almost stent diameter is 4 and 4.5.
Okay, this is
Oh,
main
great.
ostium.
Right, the big proximal, very proximal, shaft over the main as free of disease and not, And would you show us again the distal part of LED, something? So we want to have some more ideas. All right, stented area. And give me the, okay, why not? Distal landing area, very much, intima hyperplasia. Stent diameter is almost 2.5, more than 2.5. Lumen area is more than at least, 5 millimeter square or something. All right, that is, if you look at the, media to media vessel size, it's quite big ones, more than 3.5. However, stent diameter is 3.0. Okay, that is almost 4 media to media. The meaning is that is big vessel, and previous stent expansion is 3.0, maybe small, However, area concern is quite good, more than 5 millimeters something. However, still, the stent, expansion is less than the reference vessel diameter, right? Okay, stop it. There is the narrowest portion, it's 2.5 something. Okay, go ahead. Still, I personally believe still under expansion.
Yes.
Part of not related with the small stent areas. However, compared to the medial reference vessel diameter, it's still mainly stop here. That is mainly intima hyperplasia
yes.
related ISR. If we have some ideas, OCT examination, VHIs for this ISR lesion, that may be related with some. What do you think? Neo-atherosclerosis,
Yes,
etc. Some, vulnerable, plaque characteristics that's inside. However, we have some limitations using the grayscale IVs for that. Okay, go ahead. There's LED. So we have mainly intima hyperplasia. We didn't too much, get the information about the plaque characteristics itself. However, all right, proximal part stent expansion is quite good.
suck.
Okay, so we're gonna do circumflex. Okay, obvious again. All right,
Okay,
quite
got it.
difficulties, however, it's passed. Good luck, All right, that is some proximal circumflex. Artery, size-wise, C5, almost 4. I think it's quite big,
Yes.
big artery, right? 3O, at least more than 3O. And then, okay, coming out to the ostial part, a small obtuse marginal branch there from the 7 o'clock. It's absolutely free of disease.
Yes.
Okay, that is very much that one. Ooh. Okay, another wires from the LED. This is main. Okay, would you show us again? Stop. We know that what it is, right? Very interesting findings. Okay, that is polygonal, big obtuse marginal branches. Slowly. Not, okay, backward. 1 or 2, backward, a little bit further, more. Okay, that one. Go ahead. 1 or 2, slowly. Big OM branches here. Okay,
Yes.
go ahead.
Slowly.
That
Very
one.
close.
Stop.
Yes,
Stop it.
stop.
That is just, ostial part of a circumflex. It's quite big one. 2530, right?
Yes.
Big vessel, some digits, minimal digits. However, if you can clearly see that 9 o'clock, there are some wires and LED coming, right, merged with the circumflex ostial part. Those areas we named the polygon of confluence. Okay, go ahead. 1 or 2 segment there. Okay, one. All right, that one. So you can clearly see that, combining, area of circumflex ostium pretty much, disease. We have already a small balloon dilatation. Maybe related to the mottling density of a grayscale IVUS, as may suggest that some, we cannot exactly say that, however, some vulnerable plaque. Okay, go ahead, 1 or 2 segment. LED wires, we can clearly see that 10 o'clock and merge with, okay, go ahead. 2 wires, okay, stop it. That one's right, 11 o'clock. 10 and 11 o'clock, so another wires from the LED and, join, merge with the main here. And this part, look at this, circumflex ostial part, lots of plaque over there,
Yes.
right? Quite a big one, 3 of them, pretty much big one. And very focal stenosis, very tight stenosis, plaque vulnerabilities, maybe related with one. And, okay, go ahead. Okay, that one, distal laminias, right? So, okay, this
This is
circumflex.
up.
So
This
we
is
want
up.
to take a picture again.
Yes.
And after the, separate 2 lines from the LED and circumflex, right? So we have lots of, more clear informations, ideas from the IVUS examination in terms of a vessel size is big enough. Circumflex ostial part almost 3. There are And if you look at the angiographic finding, the very discrete, very much plaque burdens on the circumflex ostium. And in terms of LAD and LAD stented areas, distal part of stent would be a little bit, under expansion compared with the reference vessel diameter,
Yes.
and mainly some intima hyperplasia, right? So depending on our findings, I think it's quite clear. We're going to do 3O size, short drilled stent for the circumflex ostium. In terms of a technique concerns, Tap Technique is more easier to perform. And LAD side, what do you think? So the distal part, we need a
The more high pressure balloon.
right,
yes,
right,
yes.
non-compressed,
Yeah,
little bit bigger
non-compressed,
balloon.
Yes.
And then, if possible, we want to do the why not? Cutting balloons, more even plaque, breakdown and the even, redistribution of plaque by cutting balloons. So I believe that, and however, we cannot, demonstrate any small difference between the cutting balloon and plain balloon and the angioplasty before any procedure for the ISL lesions. However, still, if you look at the, some angiographic findings, I prefer, cutting balloon for the, okay. So, aerial caudal view, so we want to take another picture for that. Okay, that one, you can clearly see that the bifurcation area. Okay, what do you think?
Yes.
So, caudal and aerial, that is more
Tested?
test. Okay, I think it's quite more clear
Yes.
for that. Usually, spot view
Yes.
is not for the operators. However, the view is good. For that, I have no other choice, right? Okay, take a picture here. Okay, that
Okay,
one. What do you think? More clear, right? Any suggestions for that?
I presume you're going to pre-dilate to make sure both sides are quite well pre-dilated. And did you say you're going to use a tap technique?
Yes, it is. That is quite easy. Is you want to try that some, cutting balloon first and high pressure inflation and main branch, and then we're going to see what's happened. Some. So, cutting balloon 275 first.
Yes. This is LAD.
What's your
Okay,
guide
good.
cath size? Is that a 7 French guide cath? Your guiding cath.
275 cutting balloon.
Cutting balloon.
Guiding
Guiding
A
A French, joking guiding caster.
A French. So still I prefer the bigger the better. So for the complex angioplasty, like limb main, all right, still we want to move to the transradials, low profiles. However, this kind of a complex procedures, bifurcation, main, and I prefer bigger ones. Sometimes, this is something?
Side branch. Yes.
Okay, well, right, that would be. So we can clearly see that the LAD stenotic, lesion.
Okay.
Here we are.
This is
Just I
275.
want to see that floral, where it is. Okay, clearly see. We can clearly see that here. Okay, why not?
Okay. Nominal
Inflate.
6. Nominal 6.
6,
6.
7,
7.
8,
8. Just 8.
275, right?
Yes. Right.
Okay, so
Deflate.
deflate, cutting, one side cutting, and I pull the device out. Actually, I rotate the device. Believe it or not, so I want to make it another aspect. Okay, here, why not 10?
10. 10.
Why not 10, 12?
12. Okay.
Okay, deflate. One more. Okay, why not? Inflate.
6, 8, 10, 12.
There was, wires. However, I just do the cutting first. More. Pull the, system out and
Rotate.
a little bit more rotate. And all right, so it's not easy. Rotation can make it. Okay, another break. technically, rotate the balloons, make some, kinking of the two wires in the inside of the guiders, and so we don't too much, we didn't. Okay, that would be, just a minute, okay. Wires, the circumference, okay, why not?
Joe?
All right, get more smoother
Yes.
rather than we expected. And so, would you measure the distal part of LED 3.5 non-compliant? What do you think?
Yeah,
3.5.
3.5
3.5.
non-compliant.
Non-compliant.
15.
And then finally, we're gonna do this a little bit more,
This is a 3.5.
3.5.
3 point, yes.
3.5 non-compliant balloon for the high pressure inflations after the cutting balloon. We don't have data, but I believe we have a more clear, angiographic findings after the evenly break down the intima hyperplasia of ISR. And then we're gonna do high pressure inflation based on the obvious findings. We have a lot of ideas, but I want to say that, okay, maybe it's here.
Yes.
Judge the distal, right?
Yes, right.
Believe
okay.
that?
Inflate. Nominal 14.
Okay, why not?
14.
14 is optimal.
Deflate.
Why not? So we're gonna make a little bit, pull the system out, and why not? Inflate 18.
Inflate 18.
What do you think? 18. 18 atmosphere.
Okay.
Overhand balloon diameters? 3.6.
3.6,
Okay. So for the proximal LAD and left main area, why not? We're gonna do the
20.
20.
20.
Why not? 25.
25.
All right. High pressure inflation
Okay, deflate.
for the LED side. And then we're gonna see that what's happened. Okay. Test, please.
Test.
What do you think?
Good. Yes.
That's big
much
changes,
better.
right? Big changes. So still, we have another options, that we're gonna do another drug stand for the LED and left main. However, I still believe rest metal, may be better, and too much metal for the, another drug stand for that. And so I just,
Please. Okay, ready?
do,
Sure.
okay, why not?
Okay, good.
Okay, what do you think?
Well, the LED looks great, so maybe,
All right,
so maybe I'm just wondering whether you just don't want to put more metal in the LED and just use drug-eluting balloon in the LED and just stand the circumflex.
Yes.
yes,
Yes.
exactly. Right,
Yeah,
exactly
yeah,
what
right.
I planned, right? Well, what I planned that one, and so you're gonna make a good, clinical angiographic outcomes using the cutting balloon and non-compliant high pressure inflation, and result in terms of under-expansion of a stent itself, and there's a more bigger the stent area, right? Would you show us a spider view, please?
Okay, got it.
Okay, and so we're gonna, treat the circumflex ostial part for as the next time, as the next step. Okay, good. Take a picture here.
Okay.
All right, I like it. In terms of LED side,
Yeah,
it's
okay.
big enough,
Yes.
right? So we're gonna do, I think it's a 3.5 non-compliant balloon.
Yes,
for
for
for the LED,
yes.
and 275 balloon, right?
Yeah, 275, 2.75.
No, 2.5 is okay.
2.5
compliant balloon.
compliant balloon. Yes. This is
More. We need a more easy. Okay, 20 is okay. So we're gonna choose the 3.0 size. What is the shortest one?
This is the
Length of a stent.
제작.
Shortest one. Chance. 3.0, 15, 12.
12. Yes, 12.
All
or
right.
15.
I think it's,
Yeah,
you know,
15 is
15,
okay.
15 is okay.
Yes, right. This is suck. Okay.
All right, this is circumflex. We have already, you know, dilate 125 balloon. So this is a 125
Yeah,
balloon.
25, 20.
Okay, why not? Inflate
Inflate.
to that.
8,
25.
8, 10.
Just a minute. You want
Okay,
to see that? Okay, why not? 10. One more. It's quite easy. Okay, one more.
12.
12, 13,
Size
14.
14.
Okay, no
2.7.
problem.
Okay.
Is there any other indentations? No.
Yes, no indentation.
All right, so quite, I believe, quite easy to pass the
Yes.
stand for this one. Okay. All right. So
Okay.
15,
Yeah, 3 or
Okay.
15. Yes.
3O size. We wanna choose a 3O based on the IBS findings. There's big ones. So 3O,
Giants Alpine.
Giants Alpine,
Yes.
and length
The
15,
yes.
right? 15 length. So before before deploy the stand for the circumflex, we need a 3.5. We use balloon for the LED. Okay, I think it's too deep. All right. This is 15.
Yes, 15.
Okay.
Okay, good.
Not too difficult to pass the stand for. Okay, we need another balloon.
The balloon.
3.5, use the
3.5.
one, just
non-compliant.
previously used a non-compliant,
Yes.
right? I know. I placed the balloon for the LED side to kind of a safety for the final, so we need the final
불 좀 맞춰줄래?
kissing balloon inflation. So I, prefer
This is
to, all right, used one. They're a big, wing after the collapsed balloons. However, I want to try that. 3.5?
Yes, 3.5.
Okay, good. And 3.5, previously we used the non-compliant balloon for the LED. The guidance outside the ostium, however, axiality, coaxiality is good.
Okay, good.
Balloon pass is not too difficult.
Yes.
Okay, here we are.
Yes.
And then we're gonna pull the stand out a little bit in the main side. I think it's too much. I wanna just see the floor.
Yes.
Okay, I don't want too much. Okay, contrast please.
Contrast, please.
Okay, I think it's quite enough.
Yes.
What do you think? It's okay?
Yes.
Would you show us area view?
This is area.
All right, test please.
Test it.
Okay, you can
Yes.
clearly see that proximal part of stand is
Yes. Yes.
protruded. The main vessels is hanging out a little bit, right?
Yes.
Okay,
Yes.
I think it's 3.5. Spider view again.
Spiral again.
3.5 is okay.
Okay.
I'm gonna see that more. All right,
Okay.
just the ostial part, 1 millimeter further out from the side too much.
Yes.
Okay, what do you think?
Test.
Okay,
Test.
it's okay. All right, inflate.
Inflate.
Nominal 10.
10. Just nominal 10. Okay, good.
Okay. 10 is
10.
nominal. Okay,
Yes.
deflate.
Deflate.
Why not? Pull the balloon out and
Yes.
why not?
10, 12,
10, 12.
14,
16.
16.
Okay.
Deflate.
Actually, we need the, non-compliant balloon inflation for
Yes,
that.
yes.
However, the plaque characteristics is quite a soft one. The region length is short, very soft plaque, and discrete narrowing. And so I would try to, just this delivery balloon for the kissing balloon inflation, right? Okay, one more.
Suck.
16.
16.
Suck first.
16.
Okay, I know. Deflate.
Okay,
Is
deflate.
absolutely, we didn't see any indentations from the stented side. And then pull the balloon out. Here we are.
Okay.
And two balloon delivery system, it will be pulled out. LED for the, this is circumflex?
This is LED. Yes.
This is circumflex, right?
Yes, right.
Circumflex further. All right, why not? So you're gonna do low pressure, 6 is quite enough.
6.
Okay.
Okay.
I think it's quite enough.
Yes.
Dilation is circumflex ostium and LED
1,
2.
2, 3.
Okay. And then,
This is LED. This is
all
suck.
right. So finally, I will make us another. Okay, almost there. This LED
This is,
here.
yeah, LED.
Pulled out a little bit further.
Okay.
Okay, why not? Inflate 6.
Inflate 6.
During the inflation, I pulled out. So
Okay,
all the
6.
same. 6
Okay.
step. Okay,
1, 2,
deflate.
3. Yes.
And then pull the whole system out. Just wind. Okay. That is what I did. What I did is kind of a tap technique.
Yes.
And then, okay, forgot the terms of DB
Yeah.
for
Yes.
LED. So we, for the DB, treatment, we're gonna,
Oh, side branch wiring. This
sudden wire is gone.
Yes. Recross is
Okay, why not? We're gonna
Okay.
do,
Just,
so,
and you're ready.
angel force.
Shoot. Okay, good.
Ooh, what do you think?
It looks good in this view. Should we see another view?
All right. All right, so why not? Are you covered?
Okay.
So, as a next steps, the reason
DB.
why is I like a choice PD, I don't like a
Yeah.
choice PD wire, right? Sometimes it's,
Yeah, yeah, right.
not under control.
Okay.
All right, there's another view here.
Oh, great.
All right, I like it.
It looks
So,
very good. Are you going to do
As
the
the next step,
Yes, I'll do,
Togo,
yeah,
okay, you
DB.
want to do the wire. All right, right. Finally, we're going to do the kiss. However, still, we're going to make another wire
Yes, yes.
for the,
Yeah,
be
DB.
careful.
Okay, got it.
It's not as, I don't
oh.
like it, just stand short,
Okay, got it.
cross the wire.
Yes.
And then do a 3-0. Compliant, non-compliant, it doesn't matter. When the meaning is expansion is
Yeah,
good
yeah,
already,
yes,
and I think it's compliant is better,
Yeah,
right?
yes.
Compliant 3-0, and drug-eluting balloon for the LED, right?
Yes.
Distal part first, and then C5,
Yes, yes.
drug-eluting balloon kissing
Okay,
for 20 seconds,
Okay.
right?
Are you
So
going
that is
to
our
do
step. Angiographically,
Sorry, are you going to do a final IVUS to see the final result?
yes,
Final
of course,
IVUS.
we're gonna do that after
The DB.
after the drug-eluting balloon, right? All right,
Okay,
final
got
IVUS. And so we prepare
cases.
as another cases. We're gonna start in the another room, and we're gonna
Yeah,
see the
okay,
in the
I'll
later,
do
right?
that, yes.
As a very limited time, so we
Yes.
wanna make us more data.
Okay.
Right?
Yes.
Okay.
wire.
Thank you. We're gonna move to second level.
Several additional work for the final optimization. We did a drug eluting balloon for the LED instant restenosis region using the 3.5 26 drug eluting balloon, and then we did final the kissing balloon dilation using 3.5 and the 3.0. Okay. Could you show us the DB balloon? Okay. No. DB. Okay.
This is the
Okay.
final
Okay. DB. Okay. We did DB and next. 이거 아니잖아. 잠깐만.
Okay,
Okay.
go ahead. So finally, did you
Yes.
do the IVUS?
Okay. And we checked the IVUS.
Okay.
The both side, and could you
We
show
have
the
very
suck?
limited time, so
Yes.
okay.
Yes, this is the suck. And
Suck.
yes,
Circumflex?
yeah, this is circumflex.
All right. Look at this. stent diameter is almost 3. The meaning is stent area is almost 7 millimeters square, right? And so we have some
Yes,
cutoff
yes.
value is 5. And so compared to that, it's big enough, 7 millimeters square. I don't believe.
Okay, this
all
is,
right, this is confluent
the-
area
yes.
is big enough. Okay.
Okay, and then
Main-
we already checked the left main LAD. 그 정션 부위만 보여주세요.
Good.
Okay, start. Okay, and
LED here?
yes, sir. Okay. This
All
is
right,
from
so
the
look at that one. Stent diameter is almost 4. Would you check the,
okay. This is a
cross-sectional
conjunction.
area?
Yes.
Okay.
Okay, great.
So for the LED proximal here, all right, measure that.
Major.
Okay.
Yes.
So you wanna, have some confidence in terms of stent diameters and area. All right. Why not? There are some still remaining intima hyperplasia. Okay, good, perfect. Lumen area
It's
and
more than
almost 8.4
yeah,
millimeters
wow.
square.
It's great.
Proximity, right?
Yes.
The meaning is big enough and drug-eluting balloon, we're gonna expect is quite clinical outcomes in terms of stent area is the most important, predictor for
Yes.
long-term clinical outcomes.
Okay,
So,
we will check the final angle. Okay.
Great.
Shoot. Okay, great.
are you covered?
And then area quarter.
So, okay, great.
Okay, final shot.
Oh, I
It's
like it.
great. Yes.
So, Dr. Bob, good job. So, what do you think?
Yeah, looks
Very
excellent result.
quiet,
It's very,
you know.
very nicely done.
Almost,
Looks very
right,
nice.
right. So this is first cases. Maybe we don't have enough
Some
time, right?
if you want to
So
show
we're
us
gonna
the
do,
other case.
Second cases.
Dr. Bach, this is
Okay, why not move to yes.
this is an ISR case, main bifurcation. If you see the balloon
Yes.
response is not favorable for the DEB, so if you have to do another separate stenting, what will be your most preferred strategy for the poor response to balloon angioplasty for the another stenting strategy? What is your preference? The culotte or another? What will be do?
Still. All right. So we don't have any, solid answer
Yes,
for
yes.
that ISL cases, DB, and another drug-eluting stent. So now, we are conducting almost 80%, patient enrollment is conducting randomized study with a drug-eluting balloon versus another giant, stent for ISL lesion. So we're gonna have some answer in the near future, and still I believe too much metal is not so good, rather than less
always-
metals. And so
always
I
the-
prefer, practical point of view, I prefer, the DBs rather than another drug-eluting stent.
Yes, my focused question is if we cannot
Right.
apply DB alone, that is the trouble. So my personal view, the most predilection site of recurrence is the circumflex osteal area. So in the case, second stage, I prefer to do the culotte stenting to save the ISI in the left circumflex osteal area. But we don't have data. So main
Okay,
to
all right.
circumflex
option.
and another culotte stenting,
All right.
that is my most predilection strategy in case of failure to balloon
Great.
alone.
Good. So, however, I don't believe any difference in terms of whatever you choose the two-stent technique. And anyway, certain situations the culotte would be more useful, beneficial, helpful for some lesion subset. However, clinical outcome concern, even many mini crushes, DK crushes, and the culotte test, I don't believe it too much. Any difference concern. So, I would like to really tell in terms of stent areas, right? That is most important predictors. How big it is, 5, 6, 7, 8. That is our data. All right. Okay.
Okay.
네, 이렇게 해주세요.